Let me grab Michael here. You want this? You want? Can we get everybody to take your seats and we'll go ahead and get started? It's so good to meet you. So you're doing the cost, or no, the health. I mean, yeah. Yep, that's great.
So am I last as usual?
We always go last. Can I ask everybody to come on in and let's go ahead and get started? Yeah.
Health is the only one that shows up.
So we need our reporters for cost, Tom Williams and David Stevens for healthcare. You want to join us up front? And we'll do our reports from the breakout groups. Well, thank you, everybody. It's been a long day, a lot of energy. The discussions went all the way through, so thanks, everybody, for your contributions and what looked like some pretty lively discussion around trying to tackle what's obviously a difficult topic. We're going to start out for this last session by having the report outs from the three breakouts. And as each group reports out, we'll be able to have some discussion about that particular topic. And once we're done with the three, finish up with a collective discussion about ideas and questions and comments that are remaining. And so if we can finish out the last stretch here till 5:30, I think we can really take home some of the content that you all helped generate from today. We were planning to start out with cost. Tom Williams is going to report out. Oh, there's Tom. Thank you. Tom, why don't you come on up and report out?
Well, anyway, I think he's going to show up. Our moderator? Dennis? Yeah.
Sure. You want to wait and we'll just go in a different order? And,
Yeah, that'd be great.
Yeah, sure.
Thank you.
David, you want to start out?
Sure.
And we'll go with healthcare as our first group.
Okay. Got it on a board. I think one of the first things that came up was talking about what is a core measure. And we had to talk about that for a while, and I think I have to lay that on something that needs to be followed up on, because without that, having that discussion, we couldn't even get to talking about the domains. Some of the characteristics that we talked about, a core measure, were that the measures would be mutually exclusive and that they would have their own domains, but collectively they'd be exhaustive. So when you put them together, you get the whole picture. That they would all be drivers for the triple aim, that they would be sensitive to change, but you won't need an initial benchmark. So we didn't want to get stuck in having to have a benchmark for a core measure. But they had to be sensitive enough so you could track change. The core measure also, in terms of the denominator, had to be adaptable for different populations. So if you had a large measure that covered national, that you'd be able to change the denominator and do it local, regionally, or even with a subpopulation, let's say the homeless or some other population. That this measure would be connected to a system where it could learn over time and track the results and get better as a system. And one of the things that we talked about and struggled with is we looked at a lot of these measures, and they were they were snapshot measures. And people were thinking, we're thinking about episodes of care now across settings, and do we have to rethink some of these measures because they seem to be snapshots in time? So we talked a little bit about that in general. And then a concern about balancing cost and quality in core measures. We were concerned that we might have cost measures, quality measures, but everyone would just run to the cost measures and work on them and not work on the triple aim. So we had that kind of general discussion. What was interesting, even though in the beginning we weren't really sure what a core measure was, we talked about it. At the end, we generated some examples spontaneously. So examples of core measures around the triple aim, including using CAPS, composite CAPS score for patient experience, risk-adjusted mortality, which we talked a lot about, functional status, talked about a composite safety measure that's being developed now, and readmission and ambulatory care sensitive admissions as examples of core measures after we had this discussion. Now, the other part of our discussion, we went through the Institute of Medicine's the major categories to see if we thought they still fit, the ones that related to healthcare. And we thought that there's some changes, that timeliness really belonged in two places, both in patient-centered care and coordinated care, and that we thought that equitable care really belongs across all the domains. I think there was a concern that means it would be lost and nobody would do it, but what we thought it could be balanced by if we would emphasize that all populations should be looked at across those domains. And then communication, putting that in patient-centered care, so reduce some of the IOM domains. We did discuss some possible new measures that could be core measures in addition to the ones on top that are in the developmental stage. One was overall modifiable risk. It's only available for cardiovascular disease, but basically it's an Archimedes, and basically the idea is that be able to show a change in the risk status of someone with cardiovascular disease, for example. So it doesn't mean that you wouldn't be high risk, but you would be what was modifiable over time. And we did talk about execution of care plans. So we had some discussion on things that the members of the group knew that were in development. Lastly, we did talk about a number of issues. One was being able to really operationalize the measuring the patient experience, and that we do have a nationally recognized survey, CAPS, but in terms of its ability to being operationalized in all of our settings and having the data available and being able to work on it, we thought was an issue. We thought there was an issue on new medical devices around safety, and we thought that a confounder of not needing a benchmark and the measures really be sensitive to change, that pay for performance is going to be a confounder. Because there was a worry that once payers see any of these core measures, they may connect them to a pay for performance environment and obviate what our overall aim was for it. Some of the issues that we thought were related that haven't been discussed, and that is, where does medical professionalism fit? And what was meant by that is we spent a lot of time talking about the need for patients to be engaged in their care and how to get activated patients and how important that is. But there hasn't been which everyone agreed with, but there hasn't been a discussion about what changes and values that clinical professionals need in order to operate in a system around the AAA. Working in teams, for example, being facile at self-management, other kinds of skills that are very important, we thought have not been addressed, as well as capacity for providers and organizations at the local and state level for collaboration. If we're going to talk about care coordination, then organizations that involve hospital primary care specialists have to have the capacity to know how to work together, and that is going to be an issue. And that the capacity at the local area for the right mix of providers in order to be for reaching the triple aim, so that are the right mix of specialists, or the right mix of primary care. I guess our population health colleagues are going to talk about also some public health structures, or whether they're there. That was an issue that had not been discussed, but could be a deal breaker in terms of making this work. So, team out there, did I miss anything? Or would you like to add, or would you like to modify anything? Go ahead, Craig.
One question, you may have already mentioned this, in your list of the more granular areas of measurement that the group did come to, such as CAPS or readmission rates, was self-management also one of those areas? Patient-centered care.
Patient-centered care. We had a big discussion on patient engagement and patient self-management, and we had that discussion about not only being able to identify work with patient self-management, but being able to measure whether the care plan was executed over time. But we knew that was more of a developmental discussion. Yeah, that was a pretty big discussion.
Anything else from the rest of the group that was in?
Okay, thanks.
Yeah, it's interesting because it was wide-ranging, and
Sure
given
was.
the nature of it, to come down to at least a few more granular areas that people could agree on for measuring it was quite a bit of progress, I think.
Yeah.
So you did a great job.
Well, I don't know if I did great. The group did a great job, and also, I mean, part of it was, as I'm sure the other groups, we had to gel a little bit in our discussion. So I thought it was funny that at first we had no idea what a core measure was, but at the end we had lots of ideas of what core measures were. So, but still, I do think that is an issue that we'll have to be very careful about how we define it, and so that it's understandable for different audiences. I think that's the other thing. which we maybe didn't discuss that much, but we want to engage consumers and other kinds of providers. So when we talk about this, it's going to be a big challenge so people understand what it is that we want to do together.
Sure. Let's open it up, take questions, comments, thoughts from the group.
So, my question is, was your assumption that there's just a single set of measures? And I'm following, that's not my assumption. And then secondly, I know I went by them quickly, but in the concept of core set, at least as used by the Measurement Application Partnership at NQF, really talks about these families of measures that really look at how to achieve, your goals or priorities, whether it's cardiovascular care, for example, and then the core set representing those measures that apply to particular, provider type within the care system, which I must confess, early when I saw this, I wasn't really overly blown away by this way of looking at it, but I've come to get used to it, and actually it's very helpful in terms of thinking about, in a very practical sense, what a core set of measures are. So if you're thinking about triple aim for the entire healthcare system and states, federal level, providers organized in medical groups, hospitals, and so forth, it seems like it's a very useful operational way of thinking about core measures. In which case, then your discussion section in an afternoon is going to come nowhere near populating that in the right kind of way. But I think that kind of sort of general conclusion might be helpful, or rejection in some other way of looking at core measure sets might be useful. But I think that would help us, in a sense, move forward. And I think that is a starting place. So I'm curious, did you discuss it? What are the assumptions that you discussed? And, are there, because I'm underwhelmed by just simply having examples of important quality issues. There are a whole bunch of quality issues. The other thing I'll say is that we just got from CMS the measures that we have to review in the pre-rulemaking process for these 26 programs. I think there are 20 programs at CMS. There are 500 of them. And I'm told by Helen Burston it's actually 700 because we have to look at it a couple of, twice for a couple of ways. And last year we did 300. So, and there are actually good reasons why there are so many, because of the diversity of specialists in the country, the objective of engaging all of the different specialists for all the physician measures and so on. And it kind of runs counter to the common kind of conversation you have around core measures and parsimony when you really try to do this work and try to populate, a lot of programs with important measures. So I think those are some of the issues I would just throw into the conversation.
Yeah. So George, that's really helpful thoughts, and I'm wondering tomorrow, maybe during the discussion about infrastructure and implementation, the idea of repositories of measures that may be culled for different purposes and different groups, which is really, I think, what you're going to. It's very important. I'm wondering about whether that would fit into the.
These are not my ideas.
Yeah. Right. Yeah. So that didn't emerge, at least in our discussion, but and then again, there was no attempt at thinking about anything as exhaustive, more just examples. I think that was the nature of the discussion.
We certainly did mention the hundreds of measures that are out there, and because of our discussions around cost, that we may want to see what's already out there first before introducing anything else. And I think there was a notion that while we may have some core measures nationally and at the state level, that we would need a host of other kinds of measures at the local level that would impact us, so they weren't mutually exclusive.
Right.
Was that fair?
Yeah. No, I think that reflects it. I can tell you in our setting, we're trying to do the same thing, build families of measure libraries almost that can be culled for different purposes, and it's essential. I don't think that's where this discussion got to yet, though. Yeah. Maybe that is part of the infrastructure comments. Any other comments or thoughts? Yes.
Joel Hyatt from Kaiser Permanente. I guess I'm surprised that I'm not hearing more about, team-based care, the coordination of care, under the better care category. I mean, I'm sensing that that's sort of what we're looking for is more integration with all the PCMH, patient-centered medical home, accountable care organization, et cetera. I'm missing that coordination and that continuity of care kind of metric, core metric to our health system.
Well, maybe I wasn't specific enough. The group certainly supported keeping coordination as a key domain under healthcare, as well as effective patient-centered and safe and efficient. So don't get us wrong about that. We just confirmed that. We did some changes in terms of where we put timeliness and the other things that I mentioned, but there was no question about that coordination. And as you know, even realizing that we have to build the capacity for team-based care in our current organizations in terms of the professionals. So that I think in reflecting the group, I think it was a high priority. I'm sorry if you got didn't mention that enough.
Any other comments or thoughts on the healthcare?
I would just say that in the group we talked about how the coordination of healthcare is sort of a nascent field in a way in terms of how to measure it, and that would be a high priority in a way to say the first generation that's in this core set might be A, and that we would be looking in 5 years for it to be M, or that there would be some legitimate priorities in terms of which things were most crucial to be developing.
And I think it also relates to the group's feeling that we wanted to find measures that looked at the episodes of care. So that clearly would bring in the coordination. And that we were discouraged by some of them, which are more like snapshots, as I mentioned earlier.
Hi, Marcus Taguson from Blue Shield of California. I may have missed it, and I don't know that I've ever seen a metric that's been looking at this, but I'm interested in the, we tend to take these snapshots of how you're doing right now, and we tend not to focus on how people do over time. And Virginia Mason has this back pain program, and one of the things that I was most impressed with by their results was they actually measured and reported the speed with which people got back to work. And and that's the first time I've ever seen any care delivery organization actually measure the path to recovery and the speed to recovery. So I'm just wondering whether we think that that's an important dimension in terms of the quality of care, not just how long does it take you to get care, but how long does it take for you to get better? And is that something that you included in your measures? Yeah. I may have missed it, or
when we finally at the end decided we knew what a core measure was, one of the areas was functional status, which I know is a big bucket for what you just said.
Well, no, I'm not talking about actually measuring the functional status. I'm talking about measuring the pace at which it changes.
A pace at which you receive it. Okay.
We tend to, illness burden is not just sort of how are you doing right now, it's how have you been doing over the past 2 weeks, and what's the integral of that value, what's the area under the curve, and should we be measuring that as a measure of care delivery function?
Well, actually in our discussion of timeliness, we looked at not only in terms of from the patient standpoint, in terms of getting in, seeing their clinician, also timeliness in terms of coordination. In other words, how fast does this happen? There's a system working across.
So again, that's settings. Like the handoff timing.
Yes.
But the overall like end-to-end thing is, I got sick, and I got better faster when I went to Clinic A then when I went to Clinic B, even though Clinic B maybe got me in same day, they didn't get the right diagnosis. There was this and that and this and that, and 2 weeks later I was still sick. Whereas Clinic A, they got me in, they made the right diagnosis, they got me on the right treatment, and they gave me some good advice. So I managed myself well at home, and I was back to my desired functional level within 5 days. Those are very different kinds of
We
experiences.
did not discuss that, but I'm glad you brought it up.
Thanks.
I was just going to say that's an important measure in the disability community in terms of time off as well as medical health.
All right, let's go ahead and move on to our second report. And Pat, do you want to go ahead with health and report on that?
So thanks. I felt like in our group I was sitting at a table with who's who in measuring health in populations. Steve Teutsch gave a brief overview of the helpful report that he prepared for the group. And we looked at 3 different sort of topics. One was beginning with our definitions and the importance of defining the population under which or for which you define health measurements. And the key part of that being denominators or populations at risk. Obvious population boundaries are geopolitical. Public health is very comfortable with those boundaries. But healthcare often thinks about populations as people who are in the system, or subpopulations, people with rare diseases that might cross even state boundaries. And these discussions about the population are really important because it's related to the action. That the definition of a population depends upon who's asking the question, be it policymakers, government entities, health systems, even individuals as a group may want information on the health for different sized populations. We then talked about the categories, and we decided not to be embarrassed by parsimony, despite the admonition this morning. At the end, we, I think, converged on the sense that there are 2 general categories that we think of measuring the health. One is the current health, or the health outcomes, and the other is the determinants, or things that predict health, either in the future or more of a contemporary measure. Health outcomes are basically measures of death and disease or mortality, morbidity. And so we didn't get into the specific issues of how to measure those, whether it's health-adjusted life years or premature death rates, and on quality of life, whether it's health-related quality of life, your measures, or even measures of morbidity, disease incidence. Although I think as a group we talked very little about rates of diabetes. I think there was a mention of indicator diseases, like heart attack rates that could be used as sentinel indicators of a performance of a health system. But we talked mostly about length and quality of life, or mortality and quality of life measures. The other category, determinants, we had a fairly lively discussion about this as a measure, the idea that it measures really risk in populations, things that are intrinsic to individuals, health behaviors primarily, and extrinsic to individuals. And then we had a lengthy discussion about what does it mean to be extrinsic, the measure of a community, extrinsic to an individual. Is it the community's health? People have health, communities don't. I think in the end, perhaps like the Supreme Court Justice who had problems defining a certain word, this was, that I've not said in public actually, but it was what's a healthy community? It's a place where you'd like to raise your kids. That combination of measures, be it educational systems, jobs, safety, well-designed communities, the concept of a Thrive community. I didn't get the details of that acronym, but that communities are robust measures of communities that are healthy places to live. Again, the two general areas, we should measure current health, length and quality of life measures, and then some measure of future health, intrinsic to individuals and extrinsic to individuals. A lot of the discussion then was focused on the final area, which was how do we implement this? And I heard 5 themes, and I would ask others in the room to add to this. First, words do matter. Our discussion about Euroqual and health-related quality of life, people thought that those are measures that you can't really talk about in public, and people don't understand them. Even the concept of healthy communities or community well-being, that term may not be understood. Some people think of that as healthy people, and other people think of it as healthy places or environments. So words do matter. We didn't solve the question of which words should be used, but somebody who understands communication should talk about that. We had also a discussion about the contrasting ways to get the data, whether you do surveys or whether you collect the information from everybody. And there was a bit of not exactly raising of voices, but a concern voiced that it costs a lot of money to ask individuals all these questions. And others said, well, we can find ways to get information from everybody. Versus the traditional way of doing random samples. Both of those have cost. One is an episodic cost related to the sampling, and the other is an ongoing cost. The third area was indices are helpful, but they should be transparent so that it's not a black box, but that they can be helpful for summarizing information, but people should be able to look through them. The other area is should we have measures that everybody can do? And I think Carolyn used the term anchor us to the bottom, or focus on innovators, that maybe 10% of health systems or communities. And I think the sense was more the latter. Focus on innovators, so we're looking forward and not back. And then the final area was that the measures really should be actionable, both particularly in the short term, that if we had measures that were for 2050 and beyond, that wouldn't resonate with decision makers. The idea of short-term goals being set, increasing life expectancy, for example, in a specific number of years, might be a relatively short-term actionable goal. I think the sense that I got at the end of the conversation is this is something we can do. This is not theoretical. There are places that are actually measuring the health of communities or populations, and the two systems, the public health and the healthcare systems, are working together, and we could learn a significant amount from places where it's actually working. So those were my notes. Others, and I'd maybe ask for comments, additions.
This is Kevin Larson, a question. I'm really interested in this determinative health domain that you described. I'm wondering if you flesh that out some. Were you looking for actionable data on determinative health, or is this more risk stratifying different populations and areas? What's kind of the frame you have around the determinants?
Well, we didn't get into the discussion of using measures of risk to control for performance of health systems. We specifically avoided that conversation, but we wanted measures of context, that the performance of the entire health system should be measured not just by the health, length and quality of life of individuals, but by the conditions in which people live, so that healthy people can live healthy lifestyles. There was a bit of confusion on my part as to the sort of the role of the innovator, because I think we did not have a lot of discussion about the drivers, the things that could be done to move these measures of health determinants, things like health behaviors. George's slide this morning, I really like that slide, that these are of great interest to healthcare and can be influenced, but when you get to other measures of a healthy community, good education, jobs, walkable communities, that those are important measures of health and drivers of health, but may not be under the domain of the healthcare system. So I'm not sure I answered your question, but we did not talk about the use of social and economic variables for adjusting risk for the health outcomes. We talked about it as an end in and of itself.
Hi. So the World Health Organization defined health a number of years back as a resource for people and is composed of mental, social, and physical aspects. So I was wondering if your team got into those as measure concepts and also the positive aspects of health along with the idea of functional outcomes and such.
So we did not get into we said that quality of life, whether it's measured by morbidity or self-reported quality, was an important criterion, and certainly mental and physical health is a standard measure of that. Others mentioned the fact that you can have specific measures that might be proxies of quality of life, like percent of 60-year-olds who've had a knee replacement. That's a very specific measure, might be a measure of the quality of not only care, but really the quality of health in a community. But we didn't get into, we didn't really talk about, we used the examples of these measures. We didn't get into specific recommendations.
So Pat, were there several specific examples that the group seemed to have some orientation towards, specific measures of health that you would call out of the whole discussion?
Well, yeah. So in the area of length of life, the standard measures of mortality rates, this is something that health systems don't typically report because the patient's not actually a patient anymore. So specifically that all populations should look at mortality events. Life expectancy is another measure, but that's, I think George commented that that's a hard measure really to think about when you're looking at a population. And then we had a brief conversation about ways to measure health, whether you ask individuals to report on their health or whether you come up with more objective measures that are informed by morbidity and ability to function, activities of daily living. But we really, in my experience, it's really more of a question of making the decision. There's no right or wrong set of measures for health measures, length and quality of life. There are all sorts of them. And I think the recommendation was to come back to a set of a few measures rather than, there are probably 5 or 10 different measures of mortality that could be used, but probably one or a summary measure could do the job.
Did quality adjusted life years enter?
Sure. Yeah, health-related or health-related quality adjusted life years. As a single summary measure, that's a great way of putting in both quality and length of life into a single summary measure. But if that's used, I think the sense was that it should be transparent so that it has 2 dimensions, both quality and life expectancy.
Any other questions or thoughts or comments for this part of the session?
Other comments of people who were present?
Group?
Pat, I have a question. Because earlier you were mentioning about the community's health, and the paradox, this part of the triple aim, this paradox is on the population health, is healthcare will only affect, 20-some% of population health. And so the other factors are really important, and which makes this part of the triple aim has some unique properties, and you would want the community engaged. If education were a drug, I'm sure it would be, widely available over the counter because of its effect on mortality. So, did you, and to me, this is a more complex part of the triple aim, and you had a greater, I think, burden to talk about this. But how did you talk about that?
For about 15 minutes we did, and then I think people were getting agitated that the conversation was breaking down into why are we here kind of questions, or it doesn't matter anyways. In that the as you point out, the major drivers for health outcomes are outside the domain of the healthcare system, and so we're thinking of a great bit of responsibility for the integrator, and we did not have a discussion about those really programs and policies or the processes. We talk about processes of care, and we've talked a lot about whether health care data should include process measures, but we don't have a similar set of process measures for improving educational outcomes and jobs. And so I think there was some sense of disconnect between the measures of the entire health of geopolitical areas and what the discussion has been about the contribution of cost and patient experience.
The question I have is maybe we're too limited in our outlook, in that maybe we can have a measure of which we are not totally in control of, but the idea is to offer this to the community as one of the factors that we would be willing to work with them on. Because I think that George showed there were some things, he could partner on, other things he could impact on.
So I think that's the sense that we had, which is the triple aim should have measures that are outside of the traditional purview of the healthcare system, and that it would be the responsibility of the community to address those. And certainly life expectancy, age-specific mortality rates, on YPLL, other measures. If you're going to address those, you aren't going to do those in a healthcare system alone. Those are largely injury-related deaths, premature deaths related to poverty and lifestyle factors that are outside of the traditional domain. So yes, I think that was the sense, that we would not pick indicators that are limited to sort of high control for the healthcare system.
Pat, I may have missed this, but did you guys talk about what types of measures of health that providers might, where it might make sense to collect those measures, those indicators? The reason I asked the question is that, when I think about the triple aim and the idea that, George mentioned simple rules generating emergent behaviors, if providers were asking health questions, i.e. actually measuring and assessing the health of their patients, not the morbidity, but the health, that would be a different frame, a different behavior, a different rule about their work, might lead to different outcomes. Yeah. And we spend a lot of time talking to people about whether they've had their mammogram or their PSA testing, and we all now recognize that we have a certain amount of iatrogenic epidemic of early stage prostate cancer and breast cancer as a result of that, which was driven in large part, to some extent, by evidence-based quality measurement. What would happen if we had a quality measure related to physician assessment of health? Obviously, we want to have some interventions, but we do have interventions we could apply if we wanted to. Do you guys talk about any of that?
So most of the discussion about capturing data on health, on particularly quality of life, was whether it's done in the patient encounter or whether it's done routinely with people that are part of health systems. So yes, the answer to the question is yes, we think that information should be collected on states of wellness and well-being, in effect, not limited to people who come in and have a patient encounter. There was a concern from the local public health agency director that many people aren't in health systems and won't benefit from a very comprehensive measurement system for people who are actively enrolled, although most of those folks do enter a health system and I think there were some innovative ideas of health fairs and ways to really go out into the community and capture health-related information from all people. But I think the sense was that that's not necessarily an actionable item during the patient encounter, that one's health-related quality of life is a measure that really should be thought about it at the population and not right at the clinical interaction.
Do you think there are actionable health-related data points or measures that providers could be collecting that they would be able to take action on?
Good question. So others,
Something like a SF-12 or.
yeah, see, again, most people think of the SF-12 as not so helpful during the patient encounter, so
What about the example of the new annual wellness visit under CMS?
okay. So,
In fact, it's a tool to collect data that is health-related and can turn into plans to improve.
so the other idea is the health risk appraisal is a standard instrument where you do get valuable information, but then you could turn that back around and say, well, your risk age is 5 years older. So that could be used, although I think Gene and others who are looking at that information, I'm not sure that's really used in the clinical setting. Is Gene here? Do you use your health risk information?
As a way of individual risk counseling.
So you do?
Yes.
Okay, so there are other.
But I think one of the points in our conversation was that at some point, if the tool is used by so many people that it approaches census, that in fact you have an indicator of the entire population.
Yes, right. So the idea would be that rather than focusing on individual specific behaviors or even measures of quality of life, that you would measure the standard risk, use a standard risk profile. It could be used clinically to counsel patients, but then populate up measures of risk, theoretically being able then to reward people for reducing risk in populations.
Thanks.
Hi, Ed Sonic. I just wanted to comment briefly on the discussion that we had near the end of the 2 hours when perhaps we were all getting a little loopy, I'm not sure. But it was, it really, in my view, went apart from the specific goal of this breakout session to come up with a set of indicators, but really went into how the triple aim would be used to, for example, focus on reducing healthcare costs in the country. And so it really went into, I guess, implementation with a strong aim toward, I think, a goal of saying this is what this is about. It's not only about improving the situation, in a community, in an institution, or at a state, but really looking at health and healthcare quality nationally. And I think it was helped by the discussion, the wide-ranging discussion that you, I think, wisely went after and admitted of risk factors, both those that are connected to the individual as well as to the environment more broadly. And I would look forward to the discussion tomorrow on infrastructure and implementation, given what we got into today.
Well, the good news was that we concluded by asking the next presenter to give us 700 billion, was it? Maybe an even trillion. How much do we need, George?
3 years of life expectancy and 750 billion.
We'll deliver 3 years of life expectancy on our new measure if you give us $750 billion.
Pat, thank you very much. Let's go ahead and report out on cost. Tom, thank you.
It's 4:59, and we're supposed to stop pretty quick here, so.
5:30. So we have time. You take it.
Yeah, so have some notes here, but our charge was to consider core measures for, I'm sorry. Our charge was to consider core measures for cost, and our facilitators provided us a process, and that was to answer the question, what is cost, from what perspective, from whose perspective, how often do we measure it, and for what purpose? So we actually started out with purpose, and that was fairly straightforward. It didn't take us too long. Obviously, we need core measures related to the aim of lowering cost, and more specifically, lowering per capita cost. I don't know if we want to hold that up, but I'll just let you know what we covered, and that is also to explain variation in trends, to understand the drivers of cost and waste, to inform choice for plans, patients, and administrators, to inform value-based payment, and to fuel transparency. So purpose, pretty straightforward. We also had the 15-minute debate on, is this healthcare spending cost in the delivery system and the insurance cost, or is this big cost, public health? And then, of course, you move into education and just about everything. So we fairly, after 15 minutes, about the same amount of time, we hit frustration, and we decided it's healthcare spending within the delivery system. It's what we spend on payments, both to providers and out-of-pockets from patients. So insurance cost, out-of-pocket. So we narrowed that down pretty quickly. Our outcome was we came up with we had a consensus on 3 core measures, which we specified, and will be on the NQA website tomorrow morning. I'm kidding. But no, we did. We came up with 3 core measures, but we were parsimonious. We actually had quite a debate about should there be a set of sub-measures and then even more. And we decided, A, because we didn't have a lot of time, and it was really more important to have those more high-level measures. So what were those measures? Actually, let's do that one after the first 2 measures. Thanks, Dennis. And we had great facilitators, including Dennis. So the first 2 measures were per capita cost, total cost of care. One using actual cost and one using standardized cost. And we talked a little bit about some of the specifics of that, but it would have to be comparable. So risk adjustment, some of the basic things that we were talking about earlier today, so that we would be able to compare. And then, yeah, let's go to this, back to this other one, and then we wouldn't mind, so I can use the mic. And then we would be able to take those 2 core measures of per capita cost using price, standardized price, and look at them by delivery system, by geography, by types of populations, Medicare, commercial, Medi-Cal, because there are different components as you look at that in different provider settings. So, and then the third core measure was actually a really interesting one. This is Marcus's idea, and people really grabbed onto it. And that is an affordability measure, because really this is all about making healthcare affordable. So an example would be in the Affordable Care Act, as I understand, there's a percent of household income or individual income target in the benefit package. So there'd actually be a measure of affordability, which we didn't specify. We really talked about more generically. But it would be really important to have that third core measure. And then we did talk about, okay, if a provider or a community knows, gosh, we know what our per capita costs are, we know what they are in these different populations and by provider, but what do we do? So we had quite a debate about, well, should we have an underlying set of, for example, appropriate resource measures? There's a lot of consensus on what those are, but we didn't reach a consensus on that. There was sort of a strong debate of, that's too parsimonious, yeah, but it might be valuable. So I think we would need more discussion around that. And then finally, there was a discussion about, then what about really drilling down, looking at episodes of care and many other more helpful metrics for individual providers trying to develop costs. And the consensus there was that has to happen in the local market, within the delivery system, within the health plan. And I think I covered it all. Did I miss anything? Ah, implementation. Darn that implementation. So we had about a minute to discuss implementation issues, and we have a list. We could have spent quite a bit of time on that. Antitrust and distrust, HIPAA, standardization. When you're measuring per capita cost, benefit design is actually a really big issue because you have varying benefit designs, attribution, legal, and then who pays for it. So I'll ask then, did we cover it? Anybody from the group want to jump in? Okay.
How about other thoughts or questions? They challenged us with a little specificity. Please.
I would just, on this implementation side, we had a discussion at lunch on Vermont that pulling this kind of information together is really important to drive a whole lot of things, but it's not easy to pull together. So I think that last, trying to say, do we want every state, every community have to figure out how to do this? Or shouldn't we be thinking how to do it and then enable
Yeah.
that ability to analyze it in different ways, use it to drive quality increase. I don't think it's a simple last line on who pays,
Yeah.
because that's one of the stumbling blocks. It's not, we don't just turn on a dime because we've got such fragmented ways of paying for care.
Yeah, and I'm glad you mentioned that. We did not have the notion that there's some giant database where everything gets mashed together nationally, and we drive that. That we specify these measures, and then it's up to communities and delivery systems and health plans and collaboratives to do the actual measurement according to those specs.
I guess I would just raise for the group, I think that's where we've been for decades, and I think there's a point at which we actually have to gather this information so the communities can have it. Expecting all 50 states to figure out how to do this, or whatever we call community, we'll be waiting forever, and people are clamoring for it. Tell me what my starting point is, tell me how I compare. So I think maybe as a group, maybe tomorrow we could say we want to be a bit stronger than that. It's not a trivial task. Why we can spend the trillions of dollars we spend on spending it, why can't we have a little bit of money to say we should know what we're spending it on?
I think the growing, to that point, the growing number of all payer claims databases or multi-payer claims databases around the country is a reflection of how important this is, and it's a response to the need. But it's still spotty. It's growing, but it's spotty. Yeah.
Randy Siebel. I may have missed it, Tom, but it seems to me that at the end of the day, or at the end of whenever you give us the $800 billion, we ought to be able to say that we actually save some money as opposed to blunting a curve. And I'm just wondering, maybe I missed it, but did you say anything about ambulatory care sensitive conditions, which I think should be rather dramatically responsive to good behavior on the healthcare system's part, or these choosing wisely metrics that I think sort of are rampant overuse that the specialty societies are thinking, should be curbed? Just wondered whether or not the group thought about things of that sort, which I think could be addressed as sort of a subset of the total cost of care metric.
Yeah, we had a very robust discussion about what I was calling the sort of secondary level, and a lot of interest in the ability to identify waste and inappropriate variation in all sorts of categories, but didn't, and even suggested some of that subset of measures. So I think there was a lot of interest in that, but quite honestly, we just didn't have the time to sort that out. And if anybody in the group, please jump in if you want to respond as well. Rob, yeah.
Especially other types of admission. So if you're saying how you had the total cost of care, you could slice it by different characteristics, et cetera, but you would need extra processing to do care or ratio appropriateness.
And I would just add one comment. In those states where this has been done, I think what folks have learned is that the initial effort to get the data in the right usability to measure total cost of care on a risk-adjusted basis, et cetera, creates a much more usable data set to begin to do many of those other measures.
Yes, the question I have is kind of an extension of that. Is exactly what is the total cost of care by definition? Is it the direct medical cost, or is it the direct medical cost that comes through a third-party payer system? What was the thinking about the direct non-medical cost, which is often included in cost-benefit and cost-effectiveness? Was it just simply the availability of that data on a sustained basis would make it very hard to incorporate?
It was claims data, claims paid, plus co-pays patient. So those were the dollars. And it really wasn't so much that was the available data, that we felt that the aim was to lower healthcare cost spend. And those are healthcare costs. It would just get too far. We thought that the Better Health group should deal with the determinants of health and sort of that broader issue of connecting population health and the delivery system
And
spend.
so the cost of caregivers and those kind of things that are out of the health system, that's not in the...
Well, quite honestly, I mean, if a claim wasn't paid, or an estimated co-payment and co-insurance, and sue someone else, Rob, correct me if I'm wrong, then correct, it wouldn't be in that measure.
I didn't quite see the list of implementation questions. It's okay, you don't have to show it to me. So maybe that what the comment I'm